So, good afternoon or good evening to everybody, to wherever you are. I would like to give you a short introduction into the work with the corticobasal implants, and at the same time, I would like to remind you of this congress in Cartagena, in Colombia, which is going to take place 21st, 22nd in March 2025, and where I and my wife, Antonina Ihde, are going to talk, and of course a lot of other specialists for this technology of the corticobasal implants. So thanks for coming so late in the evening. Actually, this week we started the all-in-one week course here in Belgrade, in the Republic of Serbia. And on the first day, there's always a lot to discuss about the bone, about implants and bone, and so on. And this day is on this first day we are busy with the cleaning up the brains from all this, let's say, wrong or doubtful knowledge from the field of the osseointegration. So I'm a little bit tired from this, but I'm very happy that you joined us here with this. Sorry, I can't go. Okay, now okay. So my name is Stefan Ihde, and to tell you a little bit about my history, I was born in 1962 in Immenstadt in Western Germany. I studied dentistry also in Würzburg in Western Germany, and I wrote my doctoral thesis there. Later on, I cooperated in the field of research with a number of universities. So this always changed because there were different specialties in these universities available. For example, in Prague, in the Czech Republic, we did a lot of work with the Department of Biomechanics, and this was the time when we found out how much can we bend implants and how is the, let's say, the osseointegration of disc implants happening. I mean, what stages do we see and so on. At the moment, I'm limited a little bit. I only do some teaching at Jaipur University. I do this there because my good friend, Professor Vivek Gaur is teaching there, so he asked me to come, and I'm coming now already the fifth year. It's of course quite an effort to go from Belgrade or from, let's say, Central Europe to Jaipur, which is quite far away. But we do it with other professors also because we want to help there with the teaching. My clinical work started in Switzerland in 1994. I worked there until today, and later, after I moved to Balkan, especially to Montenegro and to Serbia, I opened a small clinic together with my wife, 2012 in Montenegro, and since 2017, I work in the clinic in Belgrade. Together with Professor Olga Šipić. She's a prosthetical doctor, just as my wife. And through many years already, I work as a supervising specialist and, as it's called in Russia, stomatology chirurg in Moscow. So many years I'm there already, helping doctors to implement this technology in their clinics and kind of to fresh up also the knowledge, because it's not only the idea is not that we learn things, but also we should repeat things. We should not forget things. And so it is always necessary to stay a little bit in contact with the teachers. In all those years, I have written 7 textbooks. They were translated in up to 8 languages, and I wrote more than 120 international publications. Actually, it's probably already over 130 publications nowadays. Many of them in SCI journals or in journals with impact factor. So I do this work of the publishing in order to let the university community know what is available today. I think that's also important because usually the guys in the universities are a little bit cooking in their own soup, and they don't look over the the border of the cooking pot, and it is of course necessary to tell them also what is actually going on in the world and what are the practitioners doing. I mean, practitioners like me. I see myself as a practitioner and as a professor, so I have 2 jobs, so I'm quite busy. But of course, all the experiences which I have, I didn't gain it from textbooks, but I gained it from teaching a lot of patients. These days, I was preparing the lecture for this congress in Cartagena. I was asked to give a lecture about the history of implantology, and I did this in working with this Chat GPT, always asking Chat GPT questions, and then the answers came back. And so what I'm showing you now in the next few slides was actually the answer of Chat GPT. So there, Leonard Linkow, who was born 1926, came up with the implant in the year approximately 1952. So in the early 1950s, he has pioneered our profession, the implantologist profession. He started his work with superior steel implants. And of course, after this, he invented a lot of implant types, mainly blade implants, double blade implants, and the vents. He called the screws vents. And the only implants which he didn't use was the lateral basal implants, the disc implants, which were invented by Jean-Marc Joulier and later described and used by Professor Corticobasal from France. So he lives in the south of France, and I mean, he's the backbone in in this world for the immediate loading. So he was doing things that nobody did it before. But of course, Linko also, I mean, he was the real beginner and the real starter of this professional implant business, and he wrote a lot of textbooks and articles and so on. Then I would like to mention here Stefano Tramonte, who came up with a kind of basal implants, not the corticobasal, because he was not using the corticals for anchorage, but he was using the basal bone. So he designed this screw implant, and he was inspiring, of course, a lot of doctors to use it. In Germany, we had a manufacturer called Oraltronics, so they were producing the bicortical implants, also went in this direction, but Stefano Tramonte was really the first who did it. Then I want to mention here Philippe Lederman from Switzerland. He was a true pioneer in oral implantology, particularly known for his development of the Lederman screw. So he had kind of his own implant manufactured even at that time. I mean, I'm talking about the 1980s. And he was working later with the TPS implants from Straumann, and later with the Lilleman screws, which didn't have this TPS surface. As you may remember, TPS is titanium plasma spray. This was used in the 1980s and 90s, and unfortunately, it was not such a clean surface. So when this titan plasma was sprayed onto the surfaces, a lot of copper from the nozzles, came onto the implant, and of course, the copper prevented a proper osseointegration. So there were a lot of failures with this TPS surface and with these Straumann implants actually. And later they had to switch to the SLA surface. So the SLA was an improvement, let's say, but I mean, I saw also a lot of failures with this TPS from Straumann. Now, Philip Lederman had been placing 4,500 implants, which is, of course, a lot for a two-stage implantologist. I mean, it's not a lot for us. I mean, we can place 10 times of this in a lifetime with the corticobasal implants. But I mean, he was a really very experienced implantologist, and he told me, I visited one of his lectures, he told me that he has done more than 500,000 photographs from this. So he was very well documented, very, very scientific guy. And he didn't come to the chair in Bern at the university. And this has also something to do because Straumann was moving Daniel Buser there. And Daniel Buser at that time was very unexperienced implantologist, and I mean, he faked a lot of publications and so on. I'm mentioning this because the Straumann company is so big in the world, and everybody thinks there's everything okay with this company, but I can tell you from the experience. I mean, I used to live in Switzerland, worked in Switzerland at that time. I saw this all firsthand happening. I can tell you there were a lot of very problematic things happening around the Straumann company, and I mean, for good reasons. They are now leaving year by year more and more markets, and they lose the market share. And basically, what they are doing is, I mean, we call it yesterday's wine. The next one to mention here is Gerard Corticci. And he introduced the disc implants, these lateral basal implants. So the implants were kind of placed from the side into a T-shaped slot, which was made with a turbina actually. And these implants were very, very successful. So he used the technology which was invented by Jean-Marc Joliet. Joliet was a French implantologist and researcher, and this implant was described the first time in 1975 in the United States patent of Jean-Marc Joliet. Scotecci made these disc implants very popular, especially in the southern France or in general in France, and later he combined it with the screw implants, the fractal implants. These were tuberpteroid screws mainly, and of course this gives a lot of stability and yeah, vertical stability in the distal maxilla. The problematic part of the disc implant was always the distal maxilla, but as soon as tuberpteroid implants became part of the treatment plan, there was no problem anymore. So this was around, let's say, the year 2000, 2001, 2, when we all started to place tuberpteroid implants. So I'm doing tuberpteroid implants now more than 20 years, and I can confirm you this really works. And it's also basically not difficult to learn. Okay, so then this takes us to me. I mean, this is all from ChatGPT downloaded, and well, of course, they call me the father of modern dental implantology and immediate functional loading. I mean, this is true because I worked all my life with immediate functional loading. I was only working in my first year as an implantologist as with the two-stage implants, with the Alpha Bio implants from Israel. This company, I think, it exists until today. So the implants were all okay. But from my point of view, they were not satisfying. I mean, you couldn't really equip patients with fixed teeth till the end of their life, which is basically my idea or my aim, so that everybody has fixed teeth on implants. I mean, of course, if the teeth are good, I will not take them out. But those who have no teeth or not enough teeth to eat properly, and eating properly for me means that there are first molars on the left and the right side, and then both jaws. So we are of course not replacing second molars. We are not replacing wisdom teeth, but from 6 to 6 and the upper and the lower jaw, this is what we want to give to the patient. And as you can imagine, this was not possible to do with the two-stage implants with this Alpha Bio implant. Keep in mind that when I started as an implantologist, there was no bone augmentation invented, so it was impossible to do bone augmentation. The guys like Professor Seiler in Zurich, he was doing hip transplant and bone transplant from the skull. But of course, this was all nice and was all a big show, but it had no impact on giving fixed teeth to the general population. Very few patients were treated like this, and of course he made a lot of money with this, but he was followed by nobody, basically, because nobody wanted to do it. It was very risky. Even some patients died due to the bone transplant. So I mean, basically this is all nice, but it's not possible to do it nowadays. So I was lucky to be able to work together with my wife, Antonina Ihde. We do this for many years. We run this clinic in Montenegro. And later, since approximately 2016, 17, I started to work with Professor Olja Šipić in Belgrade. We have, all three of us are co-authors to many articles, and we are leading the group of the IF teachers and writing the books together, writing articles together, and so on. And we have done a lot of implants together in all those years. We came up with a retrospective cohort study last year. This was the first time published in Antalya on the IF Congress last year in April 2024. And there we reported about 915 consecutively treated patients with 1,680 full jaw reconstructions. So to make those reconstructions, we had to, I mean, I had to put in a little over 17,000 corticobasal implants, and I had to extract a little bit more than 13,000 teeth. So the results were very good. So out of these 1,680 full jaw reconstructions, our patients unfortunately lost 19 full jaw reconstructions, and this is around 1% in those 12 years. And I think this is a very, very good result, and you will never get this result if you if you would try to do this with a two-stage implant. I'm smiling a little bit because if you want to put 17,000 two-stage implants, probably you need two lifetimes to do it because it's such a lot of work. And if you consider that the total amount of implants which I have placed is more than 70,000 implants, and I'm only 62, so there is a lot more to do. So if you really want to work hard and help a lot of patients, I mean, this corticobasal implants is the technology to use. So the key innovation was, of course, the strategic implant system, this technology, cortical bone anchorage, immediate functional loading. That's all written here. Of course, we never do any bone augmentation. We always work in immediate functional loading, and it doesn't matter how much bone the patient brings. So we will always equip the cases immediately with these corticobasal implants. If you count this all together, what I just told, then you will understand that this is a completely different technology. This has nothing to do with the osseointegration. I mean, I'm not saying that our implants don't osseointegrate, but this idea of osseointegration, you know, to put the implant and then to wait for osseointegration, then to uncover it with the healing, put the healing screw and so on. I mean, this is something that we are not doing at all. I mean, I'm not doing this at all for almost 30 years. So I work in immediate loading protocols. I make a treatment plan that works in immediate loading protocol. And if I can make such a treatment plan for the immediate loading protocol, I'm 100% sure that this will work. You see, I mean, we are not putting up the candles in the church on the weekend so that the implants from our patients don't fall out, because we are anchoring them actively in the cortical, and then we are sure this implant will stay there forever where I have put it. So this is a little bit about me. As I mentioned before, this is data from ChatGPT. You can download it in there, and you will be able to read quite a lot more about my work. So basically, I started with the screw implants, and I put a lot of these disc implants or BOI implants, and since 2006, I'm working only with the Corticobasal implant, strategic implant, or with the Corticobasal brand of implants. And this is what I will report now about. I just want to mention that if you have questions, and I see sometimes the chat, and I will then go to the chat and see what is the question? I mean, I read here, hello from Ukraine, hello to Yana, Mexico, la la la. I think you better do this in the WhatsApp, but in this chat, you can directly write questions, and I will try to answer these questions during this webinar. I want to mention here Brennemark. You know, Pierre-Yves Brennemark. I mean, he is always this. I write the osseointegration. I mean, osseointegration narrative. So why is he important? Brennemark is often celebrated as the father of oral implantology. Although it should be noted that he was not a dentist but a physician and anatomist, his most cited contribution is the introduction of the term osseointegration, derived from a single animal experiment where he observed that bone could grow on titanium surfaces without forming a soft tissue interface. Yeah, that's actually it. This was the experiment. So out of the experiment, then somehow or somebody, maybe even Mr. Brennemark, has invented the term osseointegration. But this was it. I mean, everybody talks about this guy. You know, he's the big inventor and so on. And if you look what he did in the reality, I mean, he didn't invent anything. He simply made an experiment, which in the end he didn't understand what was the result, but others understood it, and then they started with this osseointegration narrative, and it's actually a narrative. Nothing was invented there. All these implants which Linko had put from 1952 on, they were all osseointegrated, and without anybody using. Can you please turn your microphone off? Hello, I'm hearing this. And all these implants were also integrated. So this is nothing new, and only the term came up. And what actually happened that oral implantology before Nobel Biocare, before the Brennemark company, before Straumann company was very, very successful. I mean, we were working in immediate loading protocols with the polished implants. They were simply polished. There was no healing time. This word also was not invented. And as soon as then these big diameter and rough surfaced implants came on the market, the big problem started because implants got lost, patient got perimplantitis, and so on. So I mean, everybody told us, look, this is this is the latest, and you will be really successful implantologist. But in the end, all these doctors which had worked before with the implants said, this is a disaster. Can we please get the old implants back? We don't want osseointegration. We don't want the rough surfaced implants. This everything was good. Can we please get the old implants back? But the reality was that the companies were bankrupt. The old ones were either bought up by Straumann, brought up by Nobel Biocare, by Brennemark company, and they were not available. The old implants were not available. So they radically, I mean, cleared the market from all implants which really worked and started to sell us implants which was 5 times as expensive, which had the rough surface, which made an infection called perimplantitis, and which forced us to make bone augmentation and so on. This is my view on the history of oral implantology, and I of course would never use a two-stage implants with a rough surface. As I said in the beginning of my work, I was using around 100 of these Alpha Bio implants, and I mean they are good. I mean for what they claim, they are good. They are really good, but this should not be used. This type of implants should not be used today. So as I said, there was a time before osseointegration where implantology was very simple and easy. This was the time when Lenny Linko was working. He's actually one of my teachers, my personal teachers. He was working in New York. So he did immediate loading protocols within 72 hours. He never did any bone augmentation. I mean, of course, bone augmentation was not invented, but it was also not necessary. And just as today, it is also not necessary to do bone augmentation. And he worked in immediate functional loading. So, so all these things which we do today, he did also already starting from 1952, only in between. And you see here this column osseointegration. This is, let's say, the devilish phase of oral implantology, and is still ongoing because a lot of problems happened. And I mean, you know yourself, these implants don't last long. They maybe 8-10 years, and then we have to take them out. And there's a perimplantitis happening, and so on. Screws are breaking. I mean, two-piece implants are a problem by themselves because they are very small and the chewing forces are so high. I mean, I cannot tell everything now why this is so bad, why I would never use it. So I recommend, if you work now with this technology of osseointegration, completely forget that. Come to the corticobasal implantology, learn something new, learn how it's done today, and I guarantee you, you will be very happy about this. Now about me, I want to mention that I like to work in the field of knowledge. You know, I mean, I want to know what I'm doing. I want to be sure what I'm doing. I want to, test theories, and I don't want to work in the field of beliefs. A lot of things which are taught also in the universities nowadays. I would put this into the field of the beliefs. So somebody tells to someone else, and this someone else tells to another person, and so on, and everybody believes this. But unfortunately, there's no real science in the university. If you look really, what are these people doing with the root canal treatments, with the PER treatments, with other completely useless treatments, which have a lot of very bad side effects. In this you could do only if you're a good believer. But if you look at the facts, you will never do this. And so, of course, I never do PER treatment. I never do endo treatment. Of course, I even remove the teeth also myself. I don't want any endodontic treated tooth. And I mean, that's it. And then you have to think for yourself what you want, what kind of dentistry you want to do. If you want if you want to work with your brain and to understand and to know, and then to follow the rules which you will develop yourself for your life, or if you are like in this class of the good believers. But then you will be running through the fog all your life. The problem is that brainwash means nowadays that basically intelligent people are subjected to a system of belief. Basically, they are being put into a matrix. I'm not sure if you know this film, and they lose contact to the real world. They start to believe that imaginary rules and connections work. They forget to compare to the reality. Now, just in short, what is the cortical and what is the basal bone? I mean, the outer layer of every bone is the cortical, so it features low metabolism and high mineralization. Okay, so high mineralization, low metabolism, almost nothing moves. Basal bone is located at the base of the jaw bones. The opposite of basal bone would be the alveolar bone. More or less, it's not exactly true because very often teeth go through the alveolar bone into the basal bone areas if the roots are quite long. Alveolar bone is, or most of the alveolar bone is associated with the development of the facilitation of the teeth. Now, what is new in this implantology, which I want to show you here? Well, I personally consider my way of working to be the only logically correct way of doing oral implantology. So I don't believe in anything. I'm a thinker. It's not possible to hypnotize me. I never believed, for example, as in the COVID virus, I was just shocked how people run around with a mask because I mean every third year medical student must understand that these viruses don't exist. But as you see, the brainwash is if the brainwash is big enough, a lot of things can happen in the world. But I'm very difficult, or it's impossible to hypnotize me. So I'm a real thinker, and I believe in nothing actually. So because it is so logical, it means that this concept is not difficult to learn, but it has a number of aspects which are interacting with each other. So it's a little bit, let's say, complex. Okay, so it's not difficult, but it's complex. So you need to consider a lot of details when you work with this technology, and that's why you cannot learn this technology in a few weekend courses. But you need a real course. I mean, basically, you should go to the university with a few teachers and get some teaching for a few weeks, and then you know how this is being done. And this is actually what we are trying to do with the all-in-one week course here in Belgrade. And we are now actually even planning, let's say, it's called Implant Summer School. So this will be 2 weeks. So that for those doctors who have difficulties to concentrate on 7 consecutive days, so there will be a weekend in between, and a lot of things will be repeated. So you don't have to lose years and go to universities to learn this, but you can do this in a few weeks. So, as I said, this is a complex field, and you have to look upon the question from a lot of point of views. For example, from the bones point of view, from prosthetic point of view, from surgical point of view, and then you come to a solution for what is the best way of treatment. So the base of our work as implantologists is, of course, the knowledge about bone, actually the bones, because I mean, we always talk about the bone, but there are many bones inside our bone. I mean, there's an osteal bone, plexiform bone, woven bone, circumferential lamellar bone. The endosteum is also a different type of bone. So, I mean, it produces a different type of bone. So, I mean, this all has to be considered when you're an implantologist. It has to be considered when you ask yourself, why is there an infection, or why is the implant not integrating, or what happens if the implant is overloaded, and so on. And the answers to all these questions you can only get after you understand all the bone lectures. If you have listened to this 1, 2 times, 3 times, and then you are a real implantologist and you know about the bone. I'm sometimes shocked if I see doctors coming from, for example, the Straumann course. I mean, they know how to screw in the implant into the bone, but they don't know what the bone is or how it works. I mean, to give you just an example, there's a lot of theory about the cooling for when you drill this cavity for the two-stage implant. So they go with 400 rotation per minute and with permanent cooling and intermittent technologies. And we don't do this in the corticobasal implantology. I mean, I put this physics dispenser on 10 or 20,000 rotation per minute, and without water, I drill into the bone. And we all do it like this. This is in the corticobasal implantologists do this around the world. And we are only laughing about the two stages because they believe that they can damage the bone with the heat. I mean, you see, this is such a belief which is in these brains is very difficult to get out. So first of all, most important, and actually this is what we were doing also today, is to teach the doctors about the bone. All other matters come behind this. So this technology has overcome all shortcomings and problems of conventional oral implantologies. I come to this now soon, and I will write this in detail. Okay, there's one new question. Why does mono implant not require welding? I think this question is of very difficult to understand. To this DD, Dr. Dardan, can you please formulate a question without putting 100 claims in front of the question? I mean, it's not so interesting what you believe, just one question and the question will be answered. Thank you very much. Okay, the point, what is the difference between two-stage implantology and our implantology? We are using implants which from the beginning fit to the bone. So we have different lengths from 8 millimeter this implant to, let's say, 38 millimeter implant. So we will always reach the cortical, and therefore we don't have to do any augmentations because the width of the implant is very thin. Let's say the core is 2 millimeter and the diameter is 3.8 millimeter. And without augmentations, we can work in immediate loading protocol. Of course, it would be impossible to work at an immediate loading protocol and at the same time to do an augmentation because augmentations are not finished after 72 hours or 3 days. Augmentations require much longer to mature, to become to the bone or to get attachment to the bone. And at the same time, augmenting bone in our case is not possible because basically the implant is one piece and the part of the implant is in the oral cavity, and this oral cavity contains bacteria, so bacteria can run down from the oral cavity into the augmentation. Of course, this is not allowed. Augmentations require a closed environment. The other point which I want to mention here is the question why conventional oral implants tend to create periimplantitis. And of course, it's the big diameter of the implant and the rough and osseous surfaces. So the surfaces which are being sold to the two-stage implantologist as an advantage are in fact a disadvantage. They are the reasons for the failure. And if all those two-stage implants which are being placed today would be only polished, we would be in a much better situation in front of our patients. There would be much less problems. So as Professor Scotecci said this in a very simple sentence, industry has to correct this mistake in design, and they have to produce polished implants. I mean, okay, he is really a knowledgeable person. I like Professor Scotecci very much, and he put this in one single sentence. They have to produce polished implants. They have to correct the design, but I can guarantee you these companies will never move away from the rough surfaces because this is what their marketing is built on. Also, I want to do a little brainwash to you with this sentence when I'm saying only dead bone is good bone. As you know, in conventional implantology, they are talking about SL active surface, thionite, SL active, everybody talks about active. Now, if I hear the word active in connection with implantology and osseointegration, then I'm a little bit shocked. Then the last thing that I want is an active surface, because active surface means that the bone around this implant is going to be somehow modified, or it is going to be activated to do something. And if it's activated, the mineralization goes down automatically, the primary stability goes down. So the last thing that I want is all this. So I don't understand how somebody can buy an active surface which work. I mean, if it doesn't work, okay, good. It's only called active and it's 200 euros more expensive. But if it would be really active, you would see a lot of failures. So cortical bone is like a dead bone because there's almost no metabolism inside. Dead bone doesn't resorb, dead bone doesn't remodel, dead bone doesn't show any activity. Dead bone is predictable. Yeah, I mean, of course, this is a little bit ironically what I'm writing here and telling you here, but there's a important core in this. So we have to perform our implantological work in such a way that we don't wake the dead bone up. So because if the dead bone starts to remodel and starts to become active, then it can happen that we don't get the situation under control anymore. Then we see implant instability and so on. So I prefer to work with dead bone. Here's a picture with my teacher, with Professor Linko from 1997 in New York. And I have kind of crossed out this work osseointegration in my life almost 30 years ago. And I work only with the ossifixation with lateral basal implants. I work always in immediate loading protocol. And we also have no problems to remove the teeth from the patient. There's another point that I want to mention here. With the two-stage implants, with the low, let's say, survivabilities. I mean, two-stage implants last 8 to 10 years, and then most of them are out. So of course you cannot remove teeth which would last longer in order to put two-stage implants. I mean, it's a legal problem. You cannot do this, but we can do it because this type of shelf life problem with the short shelf life, we don't have it because both the lateral basal implants, also the screwball corticobasal implants, they don't have a shelf life, they don't have perimplantitis, there's no bone loss. So as soon as the implant is integrated, it will probably till the end of the life of the patient stay in this status. Nothing will happen. And in this study, which I reported about in the very beginning, which we made on the 17,000 implants, we saw that after 4 years of the implants being inside the bone, we didn't lose one case. This is a little bit astonishing, and it means also that we cannot work with the Kaplan-Meier curves. You know, Kaplan-Meier calculations, they calculate in the future how many implants are going to be in after 5 years or 10 years. So you cannot do this Kaplan-Meier calculation for corticobasal implants because after the year 4, no implants or very few implants are getting lost, and in any case, no BIPs are getting lost. So all patients stay in the end, maybe with a little bit of repair, stay in the end with a fixed incision on implants. There's of course a big difference between these osseointegrated implants and our implants. So that's what the implant looks like. So there's the apical thread for load transmission. There's a vertical shaft. It's polished, and here's this implant comes here with a cementing abutment, but there are also multi-unit abutments for screw connections. We don't work with this because this multi-unit, the advantage is, of course, you can take the prosthetics down if you want. The disadvantage is that every screw that you put in can come loose, and then the load transmission to all implants is not guaranteed anymore. And this is a real disadvantage because you have to control the patients very nicely. Constantly, you have to check if all the screws are tightened. And I mean, you can imagine if I put 17,000 implants, I have to control 17,000 screws. I mean, who wants this? So we work with the Fuji Plus and cemented constructions on the implant, and in the worst case, we cut down the bridge and renew it. This is anyway all done digitally, so it's basically much easier to work with the cemented constructions. So basically, we combine knowledge from the field of traumatology with the knowledge of the field of dentistry, with the knowledge from the field of bone physiology, and so on. So let me just look at the questions chat. Well, about this all-in-one week course, this is a theoretical course, and you will get the practical training. Oh, I see you, Pedro Savic. So probably you are a Serbian or you have a Serbian license. So this would be done either in Belgrade if you have a license to work here, or we would send you for the practical training after the course, after you pass the course, someone to help you in your clinic. And do you teach KIOS and BCS implants? Well, basically we teach BCS and TPG only. Okay, I hope this answers your question. Then another question here, how stable is the implant in the sinus area? Well, of course, the cortical bone and the floor of the sinus is not, I mean, highly mineralized, but the stability is enough. We put in the upper jaw at least 10 implants, usually 12, 14. And so a few of these implants are anchored in the floor of the maxillary sinus. So the second cortical is the floor of the maxillary sinus. And altogether, there's enormous stability. And if you would take out the bridge after 5 years or 7 years or 10 years, these implants are fully osseointegrated and fully stable. Um, why does immediate loading not require welding? Huh? Well, welding is necessary for doctors who cannot get the final bridge within 72 hours. And of course, we have a lot of technicians. We have milling machines, centering ovens, and so on. We are able to produce around 20 circular bridges in 1 week. Okay, and all our patients get this without welding. They get the final bridge. So the final bridge means that uh, that they get a zirconium, full zirconium bridge, of course. This is what we give to all patients here in the Belgrade and in the Montenegro clinic. So welding is basically for nothing. I mean, if you have your clinic at the end of the world, you don't have dentist technician, then you have to do for the first phase the welding. And of course, I mean, if you do so many implants, we do, I mean, a lot of cases in some weeks, 20 jaws, you cannot work with welding. Oh, this is too much work. It's a detour. Okay. Um, okay, so there are no more questions as I see. Okay, thank you. But you can always post questions and I will interrupt a little bit and give you my view on this. So the knowledge which you have to incorporate during this all-in-one week course is complex, but the subject is not complicated. I mean, you have to maybe ask ChatGPT what is the difference between complex and complicated. Complicated are, you know, I mean, if things are really complicated, you have to know a lot of details and nothing fits to each other and so on. This is then complicated. But complex is only that you have to have an overview on a lot of details. Yeah, as I said before, we never have patients with this situation, so our implants don't lead to perimplantitis. So we are basically very lucky. If I would imagine that that I had placed 17,000 implants, also integrated implants, and let's say only 30% of them develop a perimplantitis. This, I mean, hard to calculate. 17,000 times 30%. That's, I mean, I don't want at least 5,000 implants with the perimplantitis. I'm basically, I could kill myself. I mean, no, this is not possible to survive. The patients will kill me in the end. So I really recommend not to work with the method of osseointegration. This is so complicated. It is so damaging to the patient. So I would never do this. I mean, sooner or later, all the patients look like this, like what you see here. I mean, this is the reality. I mean, I agree. This case was stupidly solved. I mean, you can work more intelligently with corticobasal implants. But in the end, sooner or later, patient looks like this. I mean, all these implants, you know, they put the trouser down. I mean, the bone goes, and what then? You know, then there's a chronic infection, and I don't want this for my patients. No way. I want to, you know, be good friends with my patients till the end of our life. Okay, this the old method of osseointegration implies that this implant is anchored in the first cortical. This is, of course, a completely stupid idea because the first cortical atrophies away by itself. I mean, you can wait for the perimplantitis, you can wait for the problems, and that's why we anchor the implant in the second cortical down here. This is a sterile zone, and if the first cortical should atrophy a little bit away, we get a gap under the bridge, but we don't get perimplantitis. So the patient is happy and healthy, and maybe some patients, a few patients are complaining about the gaps, then we make a new bridge for them, which we anyway have designed in the digital production, so no problem to make a new bridge. It takes a few hours. We call the technician, give him the patient number, and we tell him make another bridge for the upper jaw. He doesn't even need a model. This will just run out of the computer, and so it's not a problem to fix a gap, you see. But of course, it's a problem if the patient develops perimplantitis. So if you continue with the two-stage implants, I mean, don't do it. Simply don't do it. Here's something a little bit for understanding or for imagining what we are doing. In this upper picture, you see a building that is based on a concrete fundament, and then they built this metal building on top. On the lower picture, you see different way of building. These type of buildings are created for being in the water or to be with different water levels. So if the high tide and the low tide is happening, you see that the water will be at a different level. This is exactly the same situation in the bone. The bone can grow into the height, the bone can atrophy, doesn't matter. The bridge on top is going to be always in the same position because the bridge is screwed into the second cortical. We don't care what happens with the first cortical. That's why we are so successful. And of course, we are cutting bone away if we feel the bone is too much. And then anyway, no problems can occur. Here, this picture I'm showing you just so you understand that also in the trauma field, bicortical stabilization is being done. So the implant is fixated. I mean, this implant here is the fracture plate. This is actually our bridge, no? So this implant goes from the first cortical to the second cortical. Here's the fracture, and down here is the other side of the fracture. And this is how it works. So it's of course always advisable to work with a bicortical engagement and not to put the implant only into the first cortical. I mean, this first cortical implantology, this is completely off track. This is so unlogical. And if you do this still, you really have to think about this. I mean, or you have to move every 8 or 10 years away from your patients not to see the problems. Huh? Okay, I want to move on a little bit. This is a case which we treated many years ago. And as you see, the patient came with not the really optimum hygiene bag for the control. But as you see with these EMS polishing machines, this was all cleaned. And you don't see any problem with the implants. You see, even down here, the implants are still polished. Everything is okay. So even the non-cleaners, it can be treated. So we don't do let's say hygiene phase before the implant placement. We just right away remove periodontally involved teeth, or actually all teeth in most of the cases, and then we put the implants. Here, this is an atrophy case which we treated. I remember in summer 2020. I mean, this is really quite a moderate atrophy. It could be less, and the implants were placed and loaded with this PMMA bridge, also computer designed, and this PMMA bridge was cemented with the Fuji Plus on the day 3. And here you see the picture from 2020 again, and here you see the same case in summer 2024. What you see here, this white line, and here, this white line is composite, pink composite. This is basically the gingiva which was added there by the dentist technician. And as you see, here's quite a big gap between this bridge and the base of the bone, and we left this gap because we knew that this would happen. The bone would grow up. You see here how the bone grows up. You see here how the bone grows up to here, and we had to cut here all this composite away in order so that the growing bone, the vertically growing bone, would not press against the bridge and the bridge would not break. So actually, we have with our implants not the problem that the bone goes away and everybody gets periimplantitis. This problem we don't have. We have the problem because of this very, very good functional stimulation of the bone. I mean, done by the patient, by the chewing, and kind of the forces are being brought into the bone by the implants. The bone is growing in many patients, and then we have to do this correction. We have to cut the base of the bridge. So this bridge is now actually soon 5 years in, and after 5 years, the situation usually becomes then stable, and probably we will do this year or next year the change to to a zirconium bridge. So then everything is stable. This is not my case, but here you see even the bone cut had to be made here. There was too much bone available. This is for sure an atrophy case in the upper jaw. You see that the basal bone line is above the sinus line. So this is actually what we call a complex case. Not complicated, but complex. Yeah, to remind you, no, when we put the implant, we don't go for osseointegration, but of course, osseointegration happens, and it happens because the titanium is the implant material. So the time for osseointegration, which you have learned probably in university, is 3 to 6 months, but the time to what we call adaptation and consolidation of the bone in ossifixated implants is up to 24 months. So the first 24 months, the first 2 years, we have to be a little bit careful. So here's a case. This was actually done in India by Dr. Anita Doshi, and she sent me the picture. You see on the left side, CBCT March 2016, and you see the measurement of the bone, and you see then the same implant February 2018. You see how much bone was growing everywhere on the vestibular side, on the palatal side of the implant, and you see that also the you are waving me? Yes, hi, hello. You Hi, folks. Okay, where are you? Okay, thank you. I mean, this is the result of the treatment. I mean, there's nothing special. It's not that the patient had to pay 2,000 extra to get this bone growing. The bridge is doing it automatically. The patient is the bone grower. The bone grows from the function, and we only set the conditions for the bone to grow independently. Yeah, that's what we do. And hi, Dr. Salem, hi, hello. We set the conditions so that the bone can grow. Okay, so ossifixation takes place up here, down here, and the osseointegration takes later up here. I mentioned already that we are anchoring the implant in the cortical, so the implant must go really through the cortical. So we are screwing in the floor of the nose into the maxillary sinus. We are screwing basically through the third cortical into the attachment area of the lateral pterygoid muscle for the tuber-pterygoid implants. So this you will all learn in this all-in-one week course, and all of your questions will be answered. Here are some perio cases. I like to show perio cases because there you see the craziness of this technology and how beautiful you can solve all the problems. You see here, I mean, really profound periodontal involvement, the wisdom tooth in. I mean, everything is bad here from the point of view of a conventional implantologist, but for us, it's no problem. We take this all out, wisdom tooth out, all these teeth out. It's the same case. Post-operative picture, you still see the extraction socket. And then you look here 2 years later, of course, everything's stable. The bridge was in 3 days. And all these infections, of course, disappear as soon as you remove the teeth. So there's no need to do retreatment. I mean, this is total craziness. You see, there you really see the craziness of two-stage implantology. That the patient loses the teeth because of the peri disease. Okay, also because of caries, but perio disease is the main problem, and perio disease is basically from patients who don't clean. Okay, so first for the two-stage implants, you have to educate the non-cleaner to become the cleaner, and then he has to be clean, and you give him a certificate. Now you're clean. Now we are putting to you the two-stage implants, and this cleanliness disaster. This we have to do because the implants are so susceptible to infections. I mean, isn't that crazy? I mean, basically, you give some medication to the drinker, and you know the guy drinks, and then he dies from the medication because he's a drinker. This is exactly what medicine is doing. It makes no sense. I mean, the non-cleaner, somebody who comes to us with this type of situation, I call him a non-cleaner, and the non-cleaner will stay the non-cleaner. So and why should we educate him to become the cleaner? I mean, he pays us for putting the implants and putting him something in where he can remain with his habits. You know, he doesn't have to change religion. I mean, he can just do and live his life like he always was living it, only he doesn't have any problem with the teeth anymore. This is what we are paid for. But in the two-stage implantology, they are crazy. They put these rough implant surfaces into the mouth, although they know this is all full of bacteria. This is for me completely non-logical. I mean, I don't want to talk about it. Look at this case, huh? Nice case. This is a preoperative picture. This is how patients come into the door, and we right away put them on the chair and put the implants. It's the same case, 18 months postoperatively. Now, of course, this is after cleaning. So this bridge was not really visible when the patient came for control, so then we cleaned it. Now you see it, but there's no problem with the implants. There's no perimplantitis, there's no bone loss, nothing. The implants are not affected. The bone is not affected. Now look at this case. I mean, of course, this is a non-cleaner. This patient has neglected his oral hygiene all his life, no, all his life. And you now look at this implant here, the 3 7 is it probably? Look at this situation. I mean, there's no bone at all. This tooth is kind of swimming in the granulation tissue. So we removed all the teeth in the upper and the lower jaw, put these implants here, and of course I put also an implant here, but there's very little bone here below the nerve. So the implant was a little bit mobile. So after taking the impression, I took it out and we gave it to sterilization cleaning so that we can put this implant back in when the bridge is ready, because it's too dangerous to send the patient home with such a mobile implant. And look at this. The patient came then for the 8-month control. I mean, of course, I put the implant back. Then they immediately cemented the bridge. So for some time, the bridge was holding the implant. But as you see, this is the 8-month control. Everything is okay. New bone is forming without any bone augmentation. I mean, this just heals. We didn't take out the granulation tissue, of course, because granulation tissue is a precursor to callus. And here you see the next X-ray 20-month control, and you see nothing. It's done. It's integrated. It's healed. And there was no, I swear, there was no bone augmentation whatsoever. We just put the implant and didn't take out the granulation tissue. That's all the tricks that we are doing. Okay, so I mean, slowly we have to come to an end. I think I will show you some more cases because I'm a little bit over time. So we are using nowadays these corticobasal implants, and we are using the polished compression screw. I will show you some example cases now. This case was solved in the upper jaw only. Yeah, there's one corticobasal implant, but the rest was only TPG. Of course, the bone was healed. Everything was good. Here you can put whatever implant you want. Main thing, it's polished, and of course the bridge must be ready. In the lower jaw case was solved with the BCS implant. Here you see a similar case, but these bridges are still kind of long-term temporary bridges for, let's say, 4 or 5 years. We leave them in. And these are corticobasal implants, and in the upper jaw, combination of TPG and corticobasal implants. You see here 2, 4, 6, 8, 12 implants in the upper jaw, although there is no bone basically. So this is how we work. Here's another case. You see anchorage here is in the floor of the nose, tuberopterygoid area. This is in the floor of the maxillary sinus. So we use the bone wherever we find it. Of course, in these this is the Misch classification, if you remember. So D1, 2, 3, 4. Now you can use the BCS implants right through here from D1 to D4, and of course also in this Paraskiewicz P5, P6. So where there's only a cortical and no spongious bone, and here is the cortical is even strongly atrophied. So we can treat with the BCS implants or with the corticobasal implants all these cases without bone augmentation, and the patient will be sent home with a fixed bridge within 3 days. So let's look at a few cases. These cases were operated approximately 2006. So we were still working with the disc implants. You see here the BOI implants, disc implants or BOI, and we were combining them with corticobasal implants already by that time. Sorry, the same here. Okay, these are BOI implants in the back because we didn't have the methods. We didn't have especially method 5A and 5B for the lingual cortical engagement or buccal cortical engagement. So that's why I was still working. This is probably a case from 2012, or I cannot see here. 2010. Okay, and this is how we worked for many years. That's also a case from this time. Patient didn't allow us to take out this mesodens up here, so that's why we had to leave this anterior area of the upper zone without implant. And this was done in immediate loading protocol with a full zirconium bridge with a little bit of ceramic on top. Everything was done new. here's a case. This was operated by Professor Lysenko from Kharkov. It's a very nice case. I mean, he's a maxillofacial surgeon, and of course, he's using for the implants only the real cortical, only permanent corticals. So this means the tuberotegument area here on the left side of the picture, and the floor of the nose on the right side of the picture. And whatever is in between here, this is not interesting for for maxillofacial surgeons. I mean, this is nothing. It's some shitty bone where nobody wants to have anything to do with it. Of course, we put implants there, but the real maxillofacial surgeons are not interested in this. Yeah, here are some cases from I mean, which are old, which are all many years old. Let's see, this is the 8 years follow up, and probably it's now 16 years already. I mean, this case is in the PowerPoint already many years. We can do single teeth implants. Of course, this requires a little bit explanation how we do this. We can do segments with this technology. So not only roundhouse bridges, but of course, most of the cases we do with a full mouth or full jaw rehabilitations. Okay, so here you see some cases. This was removed. There you still see the implant is missing. And this is a few years later, 4 years later, so the bone has been growing up here, of course. That's the patient. So my conclusion is that the technology of the corticobasal implant or the BCS implant has solved all problems which have existed during the time when osseointegration was used as a preferred method in oral implantology. So what we are doing is much better, much easier, much faster, and much more reliable. This is the most important thing. Much less problems, no periimplantitis, and so on. Immediate functional loading is a safe protocol if the technology of the corticobasal implants is used properly. Bone augmentations are not done anymore today. Of course, we don't do it, but they are not necessary because everybody has the possibility to start using this corticobasal technology. So let's see. This actually, what is our market? I put these slides to show you what we are doing. This is data from the Swiss clinic. Here you see 100% of the patients which we have treated with full mouth rehabilitations. Okay, upper and lower jaw, all teeth out. And there you see in this age group up to 30, we have almost 1% of our patients from this age group. Then 30 to 35, almost 2%, and here 35 to 39, almost 4% of the patients which we are treating. I mean, this was a cohort. I think it's 77 patients, and then we looked at how old have they been, and as you see, I mean, we always think that implants are placed here 40, 50, 60, 70. No, a lot of patients which are very young request full implant removal from us, and they want to be switched to the implants because they know this is a one-time investment, and after this they have for many years. I mean, we look patients. We had a control with the BO implants last week in Switzerland. The patient had the bridge 28 years and the implants 28 years in the mouth, and she was exactly 2 times for the control. I mean, where do you get this? I want to see one case with 2-stage implants after 28 years, which is still in. So we see this, of course. I mean, I have a lot of experience with this, and I have a lot of patients with more than 20 years implants in the mouth. And I can assure you this works. This is very reliable, but you have to learn it properly. I mean, you cannot learn it on a weekend course or always on Wednesday evening on the online show. Yeah, you really have to come and to discuss with the professors to get the knowledge into your brain. Now, if you look at this, you see how widely distributed are our patients from the age point of view, and of course the question is, what is our market? I mean, for whom are we doing this? Who are our customers? I mean, this is in the field of economics. This is a very important question. What is our market? So our market, in my view, are patients which want to have their teeth out. Now you might say, oh my gosh, we don't have such patients. All our patients want the teeth repaired. And then my answer will be, yeah, they want the teeth repaired because you did nothing else in the past. All you guys, dentists, repair the teeth. Nobody tells to the patient, hey, it's much cheaper to take them out after a certain amount of decay is reached. And this may be decay of the teeth, missing teeth, periodontal disease, and so on. So I mean, there's a border where you have to tell the patient, look, this makes no sense to continue. Even if I have to remove 5 or 8 fully healthy teeth, and then we put the implants in. But these 5 or 8 fully healthy teeth don't help you. You cannot eat with it. You cannot maintain your masticatory system functional if you don't remove those teeth. This is my point of view. And I mean, if you ever should come to Switzerland to the clinic, the patients for the consultation, they sit down. I mean, if we take a panoramic picture, then the patient sit on the chair. The picture is on the table. And the patient tells us, look, we don't want a long discussion here. All these teeth go out. Will you do this? And I say, yeah, of course I do this. Good. Then let's make an appointment. This is what the patient wants to know. Many patients come to us, they don't believe that we will take the teeth out, and they really want them out. This is what they wanted the last 20 years. Simply they didn't find anybody who was doing it. So if you work like we do, you will see the same. Sooner or later, this may take 2, 3, 4, 5 years. But then the rumor will spread that this really works. And then all those guys who sit at home and also all the time crying about their teeth, they will ask you to take them out. And this is the market. This is the market I'm talking about. And this is an enormously big market. There are a lot of patients. My estimation is that 40% of the patients want this out. Here are pictures from Belgrade, from the all-in-one week course in 2022. You see here Professor Vares from Ukraine working. This is here in the lecture rooms, a group from this is Dr. Tamara from Jordan, a group from Hungary coming. You see also some lectures on the picture, and this is the lecture room where everybody has this very convenient Chesterfield seat, because it's, of course, it's many hours you have to sit there. So you better have a good chair. So we installed them there so that you feel comfortable. And we have a big screen for the teaching. We are also teaching here on the board. Sorry, I need to drink something. I'm so dry from all this talking. And well, come to the all-in-one week course, come to Belgrade, you will see yourself how it works. We will explain you everything, and you will go home with a certificate, and you know how to really help your patients with or without the teeth, but of course better without the teeth, because without the teeth, the result lasts longer. So thank you very much. This was the PowerPoint, and I will look for some questions. There are 2 more questions. Just a second. Okay. If we are replacing a single upper incisor, would placing a single BCS engage the cortex? Oh, we know. Yeah, you can put 2, but for an upper incisor, I think it's difficult to put 2 implants. Or 1 will be enough, of course. Now, are there more questions? Any comment? Anything that you would like to discuss? Oh, I was talking now even more than 1 hour. Oh, Pedro, great lecture. Yeah, pleasure. It's a pleasure. I'd like to talk about implants, implants and red wine. Okay, yeah, see you soon. Thank you for coming. Consider coming to Belgrade. This is a complete course. I can guarantee you after this course, you have heard everything that you need to know. Question is if you can remember this all. So a number of doctors come 2 times. There are doctors coming 3 times on this year. I mean, this month on the all-in-one week course, there's a doctor who works only with these implants, and he came now the 4th time to this course. Of course, he's free of charge. And, but simply, I mean, the doctors come to sit in here 1 more time the week, and there are always new things that they can listen to. Also, all the professors are improving their lectures from course to course, or every month there's something new to hear. So take time, come for learning, and come to Belgrade, come to Serbia. Mixing six healthy implants. Mixing six implants only for upper jaw arch are healthy. No, we don't take all two-stage implants out. We don't leave them in. Never. And we charge also 150 euros per removal of the implant to the patient, but we don't leave them in because they are a danger. I mean, sooner or later, they are a danger. You know, the longer the traffic light is on green, the sooner it will be on red. And this is the same with the implants. The longer the two-stage implants are in, the closer is the moment when the trouble starts. You better take them out. What means never, Ryan Sali? No, we always take them out. We never leave two-stage implants in. No, no. We also take, I mean, we take them out because they tend to get perimplantitis, and we take them all out also because from the elasticity point of view, they don't fit to corticobasal implants. So you cannot splint them in one bridge. I really advise you not to do it. Yeah, thanks for coming, and we will do these type of webinars now regularly to uh, inform the doctors about this course and answer the question. Thanks for coming, and I wish you whatever, a nice day, a nice evening, or good morning. Good morning almost to India.